everybody. I was about to say good morning, but we are now in the afternoon. Just a quick side story. We had this all set up about a few months ago. I think it was sometime around September that we signed up for this particular presentation, wanting to be the first for 2020. And when we set it up and I started making reservations, the prices, hotel, plane, everything was like through the roof. Like, what the hell is going on in New Orleans on Monday, the 13th? And little did I know, coming from the East Coast, the national championship with LSU playing. So that's why the prices were through the roof. Also, I want to disclose, actually I want to apologize for my speech impediment. I do that before every single presentation. I'm from Brooklyn, New York, and if you don't hold it against me, I won't hold it against you. So the 7 steps of wound management, we decided to not really focus primarily on hyperbaric oxygen therapy. You just recently had a presentation about hyperbaric oxygen therapy and how it's used for patients who have radiation tissue damage and osteoradionecrosis. So we wanted to really expand the presentation to include all of the things that we do in our wound center here and in all of our wound centers that Restorix helps manage. For those of you who don't remember, I'm a trained adult and pediatric endocrinologist. As mentioned, I'm the Chief Medical Officer of Restorix Health, and for those of you who don't know who or what Restorix Health is and does, we're a company that partners with hospitals throughout the United States and helps them manage these comprehensive wound care center. And you have one of those here, for those of you who are not aware. You have one of those here that includes all of the advanced modalities, which we'll talk about as we go on. So I'm sure some of you, are thinking, what the hell is an adult and pediatric endocrinologist doing in the wound care world? And like you, every morning I wake up and I ask myself the same thing. How did I get involved with wound care? And the reason, and we were just talking about it, unfortunately I recently lost my mom from complications of diabetes. So this is very, along with being an endocrinologist, this is very real to me. And this is the reason why I'm involved with wound care. And I've been involved with wound care and Restorix Health from inception, so the late 90s, all the way till now, I continue to be involved. So as you see, and most of you know, and been involved with taking care of these people, 12.2% of the U.S. population has some form of diabetes. A lot of them don't even know they have diabetes, and they're walking around with their complication clock already ticking. And of those 30.3 million diabetics, 25% will develop a foot wound or a foot ulcer, which will put them at risk of losing a limb. And in fact, 20% will end up with an amputation. So of all the complications, the loss of a limb is definitely one of the more one of the biggest problems in having diabetes, and one of the more devastating, as you'll see when we look at the mortality of losing a limb. But if you compare with some of the other complications of diabetes, you'll see that a foot wound or loss of a limb or part of the foot is by far the greatest of complications. And in seeing these patients in an organized wound center, that lowers the risk dramatically, as you see. So back in the late 90s, partnering up with one of my partners who was a podiatrist, we decided to set up a wound care center up in Staten Island, New York, and really focus on the wound as the primary reason why the patient was being seen that day. Not their diabetes, not their vascular situation, not any other issue, but the wound and only the wound. Initially, the reason was to get them out of our waiting room. You know, they were in the waiting room. I was trying to develop a pediatric endocrine practice and to have my type 1 diabetics, you know, a lot of the kids that I was, the teenagers and kids in the same waiting room with some of these patients was not a good thing. So we wanted them out of our waiting room. And, you know, lo and behold, within 6 months, we were extremely busy because a lot of these patients had these chronic wounds. And as I mentioned, and this is data from David Armstrong, when compared to some of the other issues that people deal with, the loss of a limb, you know, an amputation has a 70% mortality rate within 5 years. So this is not something to discard or to look away from. And, you know, obviously as far as the cost of dealing with diabetes, in general, $116 billion is spent on diabetes, a third of which goes towards treating complications of the foot and wounds of the lower extremity. So again, this is a huge problem, and that's why our wound centers have grown dramatically, and we are now in 250 wound centers or 250 hospitals throughout the country, and from coast to coast, and keeping me very busy. So today, I want to spend some time focusing on what we've come down to 7 steps of wound management. We initially had it as 7 steps of wound healing, but not all wounds end up healing, unfortunately. So this is really more of a process as opposed to a result targeted process. So we're looking at making sure that all of our centers follow a certain a standard of care. You can only imagine back in the 90s when we first started this, it was really mostly ad hoc, everyone doing their thing, you know, depending on what type of training, your subspecialty, you know, we would all try different things to get these wounds to heal. But over the years, we brought it down to 7 very simple steps. And if we were to approach every wound using the same process, the same steps, we find that, you know, the outcome that we get is much better than those centers or offices that do not follow the 7 steps of wound healing. And if you, we'll go over each one of these and some of the data that we have in our centers to support, you know, each of these steps. And again, it's not in any order of importance. There is a sequence to evaluating a patient. When you assess and evaluate a patient, there is a sequence where you start off with the blood flow and you work your way towards the advanced modalities as you find that the wound is not responding. And again, we're talking about chronic, non-healing wounds here. We're not talking about the acute wound. We're not talking about the gunshot wound. We're not talking about the surgical wound right out of the OR. We're talking about a wound that after a period of time is not healing and is in a constant inflammatory phase that's not moving forward. So we will start off with blood flow, and way back in the good old days, you know, we were able to just document that there were good bounding pulses. You know, you would feel the pulse depending on where in the lower extremity. That was enough for everyone, including the third-party payers, to feel that, yeah, you know, we got enough blood flow going down all the way to the tips of the toes. The studies, and rightfully so, the insurers following the data that was out there now do not accept that as or enough to say that there's good blood flow to the lower extremity. So along with a full physical assessment, Most of the insurers, and including some of the manufacturers of different products, are insisting that you use something above and beyond your 2 fingers in palpating a pulse. And what they are, at a minimum, asking for is an ABI, which is an ankle brachial index, or a toe brachial index. And then again, that's a minimum. Now, as an endocrinologist, and most of you out there probably already know that in most of our patients with diabetes, an ABI, is not very accurate, because of the calcification in some of these blood vessels. The pulses are going to be very powerful, and you'll get ABIs that are above the 1.0 index. But that doesn't mean there's enough blood going down all the way down to the tips of the toes, and obviously most of our diabetic patients have microvascular disease, which ABIs do not measure. So again, if you're not happy, or if you don't think that the ABI is giving a good, clear measure of how well blood supply is, again, use whatever additional vascular testing you have available to you to fully assess that patient. It's important. And obviously, some of the tissue perfusion studies, unfortunately, one of the companies just recently declared bankruptcy, so we kind of lost that particular device, but there are others that we're in the process of evaluating, but that too is valid. Obviously, TCOMs, although they're very difficult, transcutaneous oxygen monitoring, very difficult to replicate, very difficult to do, very user-dependent, but that is also another way of measuring blood supply. But again, we're looking at non-invasive, standard measurements of blood supply to the lower extremity as we evaluate the arterial blood flow in that patient. And prior to doing anything else, prior to moving to any other step in our wound management protocol, this is key. And this should be the first thing that you think of and that you do. Because everything else, as you'll see, depends on this being in place. And again, here we're focusing mostly on arterial, and we should, because obviously we need to make sure that blood is getting down there. Again, most of our diabetics have microvascular disease, but without that blood supply, none of the things that we need for the wound to heal will occur. Obviously, various nutrients, oxygen, everything that we need, the antibiotics you're using, whether it's oral or IV, will not get down there. Obviously, various cytokines, various other markers that stimulate the wound healing process will not get down unless you have appropriate blood supply. Which, again, those are the different phases of healing that need to occur for that wound to heal. And that's probably the reason why the wound occurred in the first place and why it is now stalled. So again, you need to assess the blood supply. Now, as far as venous, we're just focusing on arterial, but it's also important to evaluate the venous return in your patient. And a lot of our patients have venous stasis and have venous stasis ulcers. Again, that leads obviously to increased edema. That increased edema is only going to delay delivery of all of the stuff that we just mentioned, nutrients, so on and so forth, further distance for all of that to travel in order to get to the wound that is present. So again, you need to evaluate the venous situation as well, and your approach is going to change if that is present. The second step is treating infection. And again, I will say that all wounds are colonized with bacteria. That doesn't mean all wounds are infected. So when you look at your patient and you look at the wound and you assess the wound, you're not, only looking at the surface of the wound and doing a swab or superficial swab to see what's on the surface of that wound, but you're looking to see if there are other clinical signs and symptoms of there being an active infection there. So you're looking for, obviously, peri-wound erythema, erythema streaking up the leg. The whole toe may look very angry, discharge from the wound, odor. Obviously, everyone here recognizes a Pseudomonas infected wound just by sniffing around the wound center. Guarantee you'll know it. For me, it's traveling in the subway in New York. I know Pseudomonas all over. So pain, some of these patients are neuropathic, and then all of a sudden, they'll complain of pain. They haven't felt a thing for the longest time, and now all of a sudden they're complaining of pain. That's because probably the toe is infected and the bone is infected, and the periosteum is now inflamed with infection, and that's why they're feeling pain. So again, that's a telltale sign of chronic osteo. Again, the tissue, obviously, around the wound, if it's friable, but the key is to get a deep wound culture and biopsy, and getting down all the way deep into the wound and getting a great, a good specimen, enough to feel confident that when you get your report back, you'll have a good representation of what's growing in there, and you'll be able to apply the appropriate antibiotic. So again, a deep tissue culture, and while you're doing that, obviously along with whatever might be growing as far as bacteria, this is a good time also to make sure that you've eliminated all of the whatever foreign object that might be in there. Remember, these patients, unfortunately, walking or they're non-compliant and caring for these for their own wounds. A lot of them are walking barefoot, and a lot of foreign objects might get into the wound and keep the wound from healing. Obviously, it's also a good time to eliminate or rule out any kind of malignancy that might be keeping this wound from healing. So again, a deep culture and looking at, obviously clinical signs of both systemic and local infection so that you can appropriately treat the infection. So that is key as far as step number 2. As we move on, obviously debridement, okay? And debridement is an area that has caused a lot of people a lot of grief because, obviously they're trying to not limit the number of and the amount of debridement that a provider performs on a given patient. What they're trying to do is to make sure that everyone is doing the appropriate amount of debridement. Unfortunately, some of these patients, will see providers that will only do debridements. Forget the other 6 steps. It's just a debridement every week, every other week. I'll see you next week, and that's all they do. So by limiting that number of debridement, now the provider has to think of other things to get that wound to heal, which again is appropriate. But let me tell you that debridement is truly the cornerstone as far as treating these wounds. As you'll hear when we talk about obviously removal of infection, removal of dead, devitalized tissue, removal of the epiboly around the wound edge that keeps the wound from fully closing and healing. Those are all things that you're going to clean and remove by doing a nice, clean debridement. And I always think of it as you're reminding the chronic wound that it's a wound. It's been there for so long. You got senescence, you got cells there that just are not doing anything. They're just sitting there. So by doing a debridement, you're making a chronic wound acute again, and hopefully in the right environment, with the right culture, or with the right dressing, reestablish blood supply, hyperoxygenation. Now that newly acute wound has a chance to heal. While if you just kept it chronic, it was never going to happen. So again, a debridement is key to getting that wound to heal. Also, you're interrupting, that surface biofilm, that, famous, mysterious biofilm that no one can see, but is there. The surface bacteria, whether it's causing an infection or not, believe it or not, through chemicals that they, secrete, are able to communicate with each other and able to create a community on the surface of the wound that will keep other cells from coming in, other cells that you need in order for the wound to heal. So even if it looks like you have a nice granular wound bed, it's important to interrupt that biofilm, and that's why we strongly recommend, as part of the standard of care, that these patients are seen weekly. They come in, even if it's just using a curette to interrupt that biofilm surface. So different types of debridement. Obviously, they've broken it down from a billing point of view to selective and non-selective, depending on how deep you go, what types of tissues you're removing, also the instrument of your debridement, whether it's sharp surgical debridement like you see in the lower part of the slide, or if you're using chemical or enzymatic or biological, it's important that you document what